My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center. I'm also the Associate Chair for Multidisciplinary Oncology in the Department of Surgery, and I am the Director of the BPREP program. BPREP is our high-risk program for women who are concerned about their risk of developing breast cancer. When we think about the treatments for breast surgery treatments include a consideration of surgery, a consideration of medical or systemic therapy, and then a consideration of radiation therapy. The order of the treatments is typically radiation therapy is at the end, it comes last. So the decisions that we make in the clinic with our multidisciplinary colleagues are often based around, does this patient need systemic therapy, hormonal therapy, chemotherapy, or therapy directed specifically at the HER2 target? And if a patient does need those therapies, should those therapies be given before surgery or after surgery? We know that those therapies, the goal of hormonal therapy and chemotherapy and anti-HER2 therapy, their primary goal is to reduce the risk of distant recurrence. And they are equally efficacious at doing that, whether we give them before surgery or after surgery. But we think about often, is there an advantage to using any of these treatments before surgery? If we use them before surgery, would they in fact shrink the tumor and perhaps allow us to do a smaller lumpectomy, resulting in an improved cosmetic outcome? Or if we know a patient has cancer in her lymph nodes, should we give these therapies before surgery to potentially eradicate the cancer cells in the lymph node and allow us to do less lymph node surgery, potentially avoiding a lymph node dissection? We make these decisions based on the molecular subtype of the tumors that we are evaluating. We know that not all tumors respond in the same way to chemotherapy or anti-HER2 therapy. And so we really want to be sure that we understand what is the likelihood of success if we're going to recommend one of these treatment options before surgery. So women who have what we call HER2 positive disease, or the HER2 receptor is amplified on the surface of their cancer cells, we know that those women are generally very sensitive, or their tumors are very sensitive to our anti-HER2 treatments. And so in a woman who presents with a tumor that may be a little bit large for lumpectomy, or in a woman who presents with cancer in her lymph nodes, if she has so-called HER2 positive disease, we are going to recommend that she get her anti-HER2 therapy along with appropriate chemotherapy in the preoperative setting. That way we know that we will not only get the long-term benefit of that treatment in reducing risk of distant recurrence, but we'll also get the short-term benefit, or I like to say the surgical bonus of that treatment, by shrinking the tumor, allowing us to potentially do a smaller lumpectomy and potentially eradicating cancer in the lymph nodes. Similarly, in women who present with what we call triple negative breast cancer, that means their breast cancer does not have receptors for any of our markers. The three markers are the estrogen receptor, the progesterone receptor, and the HER2 receptor. So if a woman's cancer does not have any of those markers, we call those cancers triple negative, and the mainstay of medical treatment for those cancers is chemotherapy. So if we know a patient is going to need chemotherapy for her triple negative breast cancer, we ask ourselves, is there any surgical benefit to giving her that treatment before surgery in the preoperative setting? Again, in women with triple negative breast cancer, we expect them to have a very nice response to chemotherapy. And therefore, when I'm counseling a woman, I can be quite confident that her tumor will shrink when she receives the chemotherapy for her triple negative breast cancer, therefore allowing me to do a smaller lumpectomy, achieving a better cosmetic outcome. And if there are cancer cells in her lymph nodes, I'm also quite confident that we will have a good chance at eradicating those cancer cells in her lymph nodes, allowing me to avoid lymph node dissection at the time of surgery. Now, in contrast, women who have hormone receptor positive breast cancer, that is either estrogen receptor positive, progesterone receptor positive, or both receptors positive, these women are less likely to have significant response to preoperative chemotherapy when it comes to shrinking tumors in the breast or shrinking cells and lymph nodes under the arm. It doesn't mean that those treatments are not effective in reducing distant disease in patients with hormone hormone receptor positive breast cancer, but we just don't see the same magnitude of the local effect in the breast or in the lymph nodes. So in these patients, if a patient is a candidate for surgery up front, if we can perform a lumpectomy, and if there does not seem to be any evidence of cancer cells in the lymph nodes, we are less likely to recommend chemotherapy before surgery in hormone receptor positive breast cancer as compared to the other subtypes that I mentioned, HER2 positive and triple negative, where we expect a much more brisk response in the tumor and the lymph nodes under the arm.